Hey there, and welcome back to the Deep Dive.
Hello!
Today we're tackling something really fundamental, the human heart.
That's right.
We've got a stack of excerpts here from a pretty serious medical textbook on clinical cardiology.
Hmm.
And our mission, as always, is to jump in, find the most important, kind of interesting, maybe even surprising bits, and, just them straight to you.
Yeah, forget wading through all that dense medical language. We're really trying to cut to the chase here.
Exactly.
Pull out those core insights that help you understand how this, incredible organ works, what can go wrong, and how experts think about fixing it.
It's like your shortcut to being better informed on a really complex, but let's face it, crucial topic.
Couldn't agree more.
So we're your guides today, helping navigate this clinical text, zeroing in on what matters. Ready to dive in?
Let's do it.
Okay, let's start where the heart's journey begins with each beat. The electrical system.
The spark plugs and wiring, basically.
Yeah, kind of like that. And when that system malfunctions, you get rhythm disturbances. And the ones that make the heart beat too fast, often called tachycardias.
Indeed. And the sources, they highlight several, let's say, flavors of these rapid rhythms. They're driven by different electrical issues, originating maybe in the atria or the junction between the atria and ventricles, or sometimes involving abnormal sort of bypass pathways, like you see in Wolff-Parkinson-White syndrome, WPW.
Right, WPW. And one that gets a specific focus in these notes is atrial flutter. What's the key thing to understand about that one?
What's really fascinating here is the pattern. On an ECG, that's the printout of the heart's electrical activity, atrial flutter often creates this really distinctive sawtooth look.
Sawtooth.
That's the atria, the top chambers, beating incredibly fast, typically around, say, 300 beats per minute.
Wow, sawtooth, that definitely paints a picture. And how fast does the main pumping chamber, the ventricle, beat then?
Well, that's where the AV node comes in. Think of it as a gatekeeper between the atria and ventricles. In flutter, this gatekeeper usually only lets through a fraction of those super fast atrial beats.
So it blocks some of them.
Exactly. So
Yeah.
the ventricle might beat at, say, exactly half or a third or even a quarter of the atrial rate. That's why you often see these ventricular rates that are kind of neat integer fractions, like a 2.1 or 3.1 block.
Right.
And if you don't see those sawtooth waves clearly on the ECG, sometimes things like bearing down, vagal maneuvers, or giving a drug called adenosine can temporarily slow down that AV node gatekeeper and sort of unmask, reveal the underlying flutter rhythm. It's also, interestingly, quite common after heart surgeries like bypass.
That makes sense. Slow things down to see the hidden pattern. Now, still on these fast rhythms, the sources point out a really crucial safety issue. Using certain common rate control drugs, digitalis, beta blockers, calcium channel blockers, it could be dangerous if you have both atrial fibrillation and Wolff-Parkinson-White.
Yes, that's a critical point.
Why is that combo so risky?
Well, in WPW, you've got this extra abnormal electrical wire, essentially connecting the atria and ventricles, bypassing the normal AV node gatekeeper.
Right.
Now, if you have AFib on top of that, the atria are already chaotic and super fast. If you give drugs that block the normal AV node pathway, you might accidentally funnel all those rapid chaotic signals down the abnormal bypass pathway.
Oh, I see.
And that bypass pathway can conduct signals much, much faster than the AV node. This can lead to an extremely fast, potentially life-threatening ventricular rhythm.
Okay.
So knowing if WPW is present is absolutely vital before using those particular drugs for AFib.
Got it. Okay, so that's the fast side. Let's flip it and talk about the slow rhythms, the heart blocks.
Right. These are issues with the electrical signal getting from the atria to the ventricles.
Okay.
The mildest form is first-degree block. On the ECG, the signal just takes a little longer than normal to make that journey. You see a prolonged PR interval.
Is this issue?
Usually not. It's often benign, sometimes seen with things like rheumatic heart disease or certain meds like digitalis, and generally doesn't need treatment.
Okay. What happens in second-degree block?
So here, the signal sometimes fails to get through completely, and there are two main types.
Right.
Mobitz type O, also called Wenckebach, is kind of like a train slowly losing steam. The signal takes progressively longer on each beat until finally one beat just doesn't make it through at all. A QRS complex, the ventricle beat, is dropped. This one is often less serious, sometimes just related to increased vagal tone, and usually pretty well tolerated.
And type 2, you said it's more concerning. What's the difference?
Mobitz type 2 is, more unpredictable and definitely more serious. Here, the signal is conducting normally or maybe taking a consistent longer time, but then just suddenly, out of the blue, a beat is blocked. No prior warning, no progressive delay. What's concerning here is that this pattern often signals a problem lower down in the conduction system, and it can progress unexpectedly to complete heart block. That's why, especially if the heart rate is slow or it's causing symptoms like dizziness or fainting, it often warrants putting in a permanent pacemaker, just as a precaution.
Which brings us neatly to the most severe, complete, or third-degree AV block.
Right. In complete heart block, that electrical conversation between the atria and ventricles, it's completely broken down.
No connection.
None. No signals from the atria get through to trigger the ventricles, so the atria just beat away at their own, usually faster rate.
Okay.
And the ventricles have to rely on a slower backup pacemaker somewhere lower down in the system. They end up beating totally independently.
So the ventricles are just, like, running on their own backup battery.
Essentially, yes. And this backup, or escape rhythm, can come from different places below the block. Where it originates affects how fast it beats and what the QRS complex looks like on the ECG.
And some escape rhythms are better than others.
Definitely. A faster, more reliable escape rhythm from higher up, closer to the AV node, is generally better than a very slow, unreliable one originating way down in the ventricles.
And this is exactly why cardiac pacing exists, right? To fix these slow rhythms.
Absolutely. When these slow rhythms cause symptoms, fainting, dizziness, or if they're just dangerously slow or unreliable, a pacemaker is needed.
How do they work?
Well, temporary pacing can be an emergency fix, sometimes done right through the skin. But for longer-term support, wires or leads are typically threaded through veins into the heart chambers. Surgical placement is also an option.
And they're getting smaller, too. Right?
Yeah, it's fascinating. We're seeing the development of these tiny leadless pacemakers that actually sit directly inside the heart chamber itself. No wires needed running through the veins.
These pacemakers are pretty smart now, aren't they? They can adjust to what you're doing.
They certainly can. Sensor-based pacing is designed to increase your heart rate when you're more active, trying to match your body's metabolic needs. They use sensors to detect movement or changes in your breathing rate.
But I can imagine something like that could get tricked, maybe.
You're absolutely right. For example, a simple activity sensor might mistake shivering or even a tremor for physical activity and inappropriately speed up the heart rate when it's not needed.
So how do they deal with that?
Well, to tackle this, some of the newer devices actually combine two different types of sensors, maybe a motion sensor plus a breathing sensor, to get a more accurate picture and confirm that an increased rate is truly needed.
Makes sense. And these devices, pacemakers included, they can still have problems, right? Malfunctions.
As with any technology, yes. The sources outline a few key issues. Things like the pacemaker missing the heart's own beat when it shouldn't. That's called undersensing.
Okay.
Or it might detect electrical noise, like from muscle activity, and think it's a heartbeat when it isn't. That's oversensing.
Right.
Or it sends a signal, but the heart muscle doesn't respond. That's non-capture or failure to capture. Undersensing, for instance, can happen if the heart's own electrical signals are weak, or maybe coming from an abnormal place like a PVC, making it harder for the device to see them properly.
Okay, so pacing helps with the slow rhythms. What about the dangerously fast ones?
That's where the implantable cardioverter defibrillator, the ICD, comes in.
Right.
Its main job isn't really to prevent the fast rhythm from starting, but to be that crucial safety net that stops it once it does start, especially those life-threatening ventricular tachycardias or VT.
How does it stop them? Does it always shock the heart?
Not always. Often it first tries using a rapid series of gentle electrical pulses called anti-tachycardia pacing or overdrive pacing. The patient usually doesn't even feel this. But if that doesn't work, or if the rhythm is total chaos, like ventricular fibrillation, VF, then yes, the device delivers a shock to reset the heart. That shock is definitely felt, but it's designed to prevent sudden cardiac death.
And they work well.
Remarkably well. Studies consistently show they significantly reduce the risk of sudden death by like 50% or more in some cases, whether you've already had a dangerous rhythm or are just considered at high risk for one.
Wow. And catheter ablation, that's another tool in the box for rhythms.
Yeah. Think of ablation as mapping the heart's electrical pathways very precisely and then using targeted energy, often heat or cold, to eliminate the specific tiny spot of tissue that's misfiring and causing the problematic rhythm.
Like fixing a short circuit.
Exactly. For VT, it's about finding and zapping the spot where that short circuit is happening. It tends to work best for specific types of VT, particularly those that are well tolerated or occur in hearts without major structural damage. It's also often used alongside an ICD in high-risk patients, not to replace the ICD, but to reduce how often they actually get those dangerous rhythms and need the ICD to intervene.
All right, so we've covered the spark and the wiring, the electrical side. Let's shift gears now and look at the heart's physical structure.
Yeah.
The valves, the muscle itself, and the blood vessels.
Right, moving from the signals to the chambers and the pipes, let's start with valves. These are the heart's one-way doors, and when they don't work right, it causes problems. Aortic stenosis, where the main valve leading out of the heart is narrowed, is very common.
What would someone, say, listen for, like with a stethoscope?
Good question. On examination, the classic finding is a murmur. That's the whooshing sound blood makes squeezing through the narrowed opening. With aortic stenosis, it's typically a mid-systolic murmur. Meaning it happens when the ventricle is squeezing. It often has this crescendo-decrescendo shape, gets louder, then softer. And interestingly, the timing of when that whoosh is loudest can actually give you a clue about how severe the narrowing is. Oh. Generally, the later the peak sound occurs during the squeeze, the tighter the valve.
So timing matters more than just how loud it is.
Exactly. Timing is key. But, assessing stenosis isn't always simple. The sources point out some complexities.
Like what?
Well, sometimes the flow across the valve is low, even though the valve opening looks really small on imaging. That's sometimes called paradoxical low flow, low gradient AS. And there's this other phenomenon called pressure recovery.
Pressure recovery?
Yeah, basically downstream pressure changes can make Doppler ultrasound measurements look worse, more severe than what a catheter placed directly inside the heart might measure. This is apparently more likely when the aorta just beyond the valve is small, less than 3 centimeters. Even things like eccentric jets of blood shooting off at an angle can make measurements tricky.
And what if this shows up in kids? Is the outlook different?
That's an interesting point raised. The prognosis in childhood seems to depend heavily on how severe it is initially. Kids with milder narrowing are less likely to need surgery early on compared to those with more significant stenosis, although, many might still eventually need an intervention later in life. And if they do need surgery as kids, needing another operation down the line is pretty common.
Okay, let's move to the next valve, aortic regurgitation. The leaky one.
Exactly, AR. This is where the aortic valve doesn't close tightly after the ventricle squeezes, so blood leaks backward into the ventricle.
What are the signs?
Often you can have a really long period with absolutely no symptoms. Then eventually you might develop signs of heart failure or chest pain. On exam, because blood is leaking back, you get a wide pulse pressure. A big difference between the top and bottom blood pressure numbers and some characteristic signs in the peripheral pulses. Crucially, the murmur you hear is diastolic.
Diastolic.
Yeah, it's a whooshing sound heard when the ventricle is relaxing and filling because that's when the leak is happening back into the chamber.
So, if someone has severe AR but feels fine, how is that managed?
That's a key question. For severe AR without symptoms, keeping a close eye with regular echocardiograms is vital. Long-term medication to dilate blood vessels hasn't shown consistent benefits across the board, but definitely if blood pressure is high, treating it with vasodilators is recommended.
And surgery.
Right. The decision point for surgery is fascinating. Valve replacement is typically recommended once the left ventricle starts showing signs of strain. That means either the squeezing function, the ejection fraction, drops below 50%, or the chamber itself gets significantly enlarged, say, over 5 centimeters in diameter.
Why then?
Doing surgery at that stage helps prevent irreversible damage to the heart muscle. But the timing is tricky. Wait too long, and the surgical risk goes up and the heart might not recover fully. Intervene too early, and you subject someone to surgery maybe unnecessarily soon.
So how do they decide if it's borderline?
Assessing how well the person performs on exercise testing can sometimes help guide that decision if the echo findings are kind of on the fence.
Okay, let's head over to the mitral valve now, mitral stenosis.
Mitral stenosis, MS, is a narrowing of the valve between the left atrium and the left ventricle. So it makes it hard for blood to flow forward from the top chamber to the main pumping chamber during that filling phase. This blockage increases pressure in the left atrium. And that pressure difference, the gradient across the valve, gets even bigger when the heart rate speeds up.
Why that?
Because there's simply less time for blood to squeeze through that narrow opening during each beat when the heart is beating faster. Less diastolic filling time.
And what are the knock-on effects of that high pressure building up in the left atrium?
Yeah, this is where the dominoes start to fall. Chronically high left atrial pressure makes the left atrium enlarge, sometimes massively. This dramatically increases the risk of developing atrial fibrillation, AFib.
Oh, okay.
And if AFib develops and the heart rate is fast, it shortens that filling time even more, pushing the left atrial pressure even higher. This pressure then backs up into the lungs,
Right into the lungs.
causing pulmonary hypertension, high blood pressure in the lung arteries, and eventually it can strain the right side of the heart, leading to right heart failure. It's a whole chain reaction.
Can doctors actually measure this blockage directly inside the heart?
They can, using cardiac catheterization. By putting thin tubes, catheters, into the chambers and measuring the pressure in the left atrium and the left ventricle at the same time during diastole, the filling phase, they can see and quantify that pressure difference, the gradient, across the narrowed mitral valve.
And tachycardia makes it worse.
Exactly. The sources note that if the patient's heart rate is fast during the measurement, that gradient will look even higher because of that reduced filling time we talked about.
Now, when a mitral valve needs replacing, there's a big choice, right? Mechanical versus bioprosthetic.
That's a key decision. Mechanical valves are very durable, designed to last a lifetime, essentially. But the major trade-off is needing strong blood thinners, like warfarin, for the rest of your life to prevent clots forming on the artificial valve surface.
And the other option.
Bioprosthetic valves made from animal tissue, like cow or pig tissue. The big advantage is avoiding lifelong, high-intensity blood thinners. But the downside is they eventually wear out and will likely need replacing, usually somewhere in the 10 to 15-year time frame.
Is there anything specific about the surgery itself?
Well, one interesting surgical point mentioned is trying to preserve the chordae tendineae. Those are the little strings that naturally attach the valve leaflets to the heart muscle. Keeping those intact during mitral replacement surgery seems to help the left ventricle function better afterwards.
That makes sense.
Also, a practical point from the sources, bioprosthetic valves put in the mitral position seem to carry a slightly higher risk of blood clots breaking off and traveling elsewhere, embolizing, compared to those in the aortic position.
Real. Why?
The flow dynamics are different. That's why aspirin is generally recommended for bioprosthetic mitral valves, and sometimes warfarin is even used for the first few months after surgery while the body's own tissue grows over the new valve framework.
And you mentioned before the newer blood thinners, the OACs.
Right, absolutely not for mechanical heart valves. That's a critical safety point reiterated here.
Okay.
Warfarin is still the standard.
Okay. And you briefly mentioned a rare valve issue earlier, carcinoid valve disease.
Yeah, this is a pretty unique situation. It causes valve damage, often affecting the right side of the heart, especially the tricuspid valve. It's caused by certain substances, particularly serotonin, released by carcinoid tumors located elsewhere in the body.
So the tumor isn't in the heart.
Correct. The substances travel through the blood and cause these abnormal plaque-like deposits on the valve leaflets. Cardiac involvement makes the prognosis worse, unfortunately, though surgery might help some patients if it's caught early enough.
Okay, moving on from the valves now to the heart muscle itself, the myocardium, and the sac around it, the pericardium. Myocarditis inflammation of the heart muscle is discussed.
Right. And the sources say there isn't one single specific echo finding that definitively says this is myocarditis.
But echo is still useful.
Oh, absolutely. It's incredibly useful because it helps rule out other problems that could be causing similar symptoms, like valve issues or structural abnormalities.
What can echo show in myocarditis?
Well, it can show different things depending on how severe the inflammation is. In really severe fulminant cases, you might actually see the ventricle wall looks thickened, maybe due to swelling or inflammation. In more typical acute cases, you often see the ventricle is dilated, enlarged, and squeezing poorly, usually globally.
Any other signs?
Yeah. You might also see leaky valves like mitral or tricuspid regurgitation, or sometimes fluid collecting around the heart in the pericardial sac. That's myopericarditis.
How about when the heart muscle is damaged by external substances? Toxic cardiomyopathy.
Yeah, caused by things like alcohol, certain drugs. The absolute first step, the sources emphasize, is always to remove or minimize exposure to whatever offending agent is causing the damage. If it's alcohol, stopping drinking is paramount.
And treatment.
Generally, standard heart failure medications are used, but there's a specific caution highlighted for cocaine-induced cardiomyopathy.
That's it.
You need to be careful with beta blockers. If someone with cocaine cardiomyopathy uses cocaine again while on a beta blocker, there's a risk of something called unopposed alpha effect. This could dangerously spike their blood pressure and potentially cause coronary artery spasm, so caution is needed there.
Right. And damage from cancer treatment.
Yeah.
Anthracycline cardiotoxicity was mentioned.
Yes, this is a well-recognized and important potential side effect of certain chemotherapy drugs, particularly the anthracyclines like doxorubicin.
Is it dose-related?
Very much so. The risk is higher the larger the total cumulative dose of the medication someone receives over time. The risk is also increased if someone already has heart disease, has had radiation therapy to the chest area, or is receiving other drugs that can also be toxic to the heart.
Okay. Let's talk about a different type of heart failure with preserved ejection fraction, or HFpEF. Here, the squeeze seems okay, but it's more about the relaxation.
That's a really good way to think about it. The ejection fraction, the percentage of blood pumped out with each beat, is relatively normal, often above 50%, but the heart muscle itself is stiff. It doesn't relax properly to fill efficiently between beats.
And what's the consequence of that stiffness?
The main consequence is that these hearts struggle to increase their output, to pump more blood when the body needs it, like during exercise or even just when the heart rate goes up. They can't fill quickly enough to keep up.
What typically lands someone with HFpEF in the hospital? What triggers an acute episode?
Good question. The most common triggers for acute worsening or decompensation are things that put extra stress on that stiff heart's ability to relax, or things that increase fluid volume. Uncontrolled high blood pressure is a huge one.
Makes sense.
Also, arrhythmias like AFib, not taking medications or following a low-salt diet, kidney problems, worsening valve disease, or even infections can all push someone over the edge into acute heart failure. Recognizing and managing these triggers is key to preventing hospital stays.
And diagnosing it.
Crucially, the sources stress that diagnosing the underlying diastolic dysfunction, the relaxation problem, requires looking at multiple different parameters on the echocardiogram. It's not just one single measurement. And you always have to consider the person's age, because heart relaxation naturally changes, tends to slow down as we get older.
Got it. Finally, in this section, let's touch on constrictive pericarditis.
Right. This is where the pericardium, that sac around the heart, gets stiff, thickened, or scarred down. It essentially forms a tight shell around the heart that restricts its ability to fill properly, especially during inhalation.
How do you see that?
Imaging techniques like MRI and CT are particularly good here. They can clearly show the pericardium itself, measure its thickness, and look for calcium deposits within it, which are common in constriction.
And echo.
Echo is also key. It looks for specific patterns caused by the constriction, like how the septum, the wall between the ventricles, might visibly bounce or shift with breathing because the external pressure changes are transmitted directly to the chambers. There are also specific Doppler findings related to how blood flows into the heart and in the veins leading to it.
Can you have constriction even if the sac looks normal thickness?
Yes, and that's a really important point the sources make. You can still have the physiology of constriction restricting the heart, even if the pericardium doesn't look thickened on the scan. Apparently, this happens in up to maybe 20% of cases, so you can't rule it out just based on thickness alone.
Okay. Moving out now to the vessels that feed the heart muscle itself, atherosclerotic coronary artery disease, CAD.
Right, CAD. This covers the whole spectrum of problems caused by plaque buildup, atherosclerosis in the heart's arteries. It can range from being completely asymptomatic, no symptoms at all the way to causing sudden cardiac death.
And angina.
Angina pectoris is the term for that symptomatic chest discomfort or pain you feel when the heart muscle isn't getting enough oxygen because of blockages, or sometimes spasm in the arteries. There's an imbalance between oxygen supply and the heart's demand.
And acute coronary syndromes like heart attacks, what's happening there?
ACS, which includes unstable angina, and STEMI, non-ST elevation MI, and STEMI, ST elevation MI, typically happens when one of those atherosclerotic plaques ruptures or erodes.
Okay.
This exposes the inside of the plaque, and a blood clot, a thrombus, quickly forms on top of it, severely blotting or sometimes completely cutting off blood flow in that coronary artery. The difference between UA and STEMI relates to how complete and prolonged that blockage is and whether it causes significant heart muscle damage.
Now, for patients with unstable angina or NSTEMI, there's often a decision about revascularization, using balloons and stents, PCI, or bypass surgery, CAB. What do the sources say about that choice?
Well, it's complex, but the sources touch on it, referencing older trials like BEAR-I. While not a direct comparison solely in the USAN STEMI population here, these trials looked at patients with multivessel disease. They found that compared to PCI, which was mostly balloon angioplasty back then, CIBG generally provided better relief from angina symptoms and reduced the need for repeat procedures later on.
Any difference in long-term survival?
Yes, and this is a crucial insight highlighted particularly from BERI. CIBG seemed to offer a better long-term survival benefit, and this was especially true for patients who also had diabetes.
Interesting. Now, a very severe complication after a heart attack can be cardiogenic shock.
Yes, cardiogenic shock is basically when the heart muscle is so severely damaged, usually after a large heart attack, that it simply can't pump enough blood to meet the body's basic needs.
How is that defined?
Hemodynamically, it means very low cardiac output, typically measured as a cardiac index below 2.2 liters per minute per square meter, often accompanied by high filling pressures in the heart, like a pulmonary capillary wedge pressure over 15 millimilli Hg, though there can be exceptions.
What's the outlook for someone in cardiogenic shock? Has it changed?
It really has, remarkably so. The prognosis used to be incredibly grim, with mortality rates over 80%.
Wow.
But now it's significantly better, below 50% in many centers, and this huge improvement is overwhelmingly attributed to one thing: rapid revascularization, getting that blocked coronary artery open quickly, primarily with PCI.
So time is critical.
Absolutely critical. The sources also mention factors that predict a poorer outcome, things like a very low pumping function, ejection fraction, having extensive coronary disease, a very fast heart rate, low blood pressure, or severe leakage of the mitral valve. Interestingly, one large registry study found that a measure called cardiac power, which combines blood pressure and cardiac output, was a very strong hemodynamic predictor of survival.
Okay. Pulmonary embolism, PE, is another serious vascular issue mentioned.
Yes, PE, a blood clot that travels to the lung arteries. It can be notoriously difficult to diagnose because the symptoms are often very nonspecific.
Like what?
Shortness of breath, rapid breathing, chest pain, fast heart rate, things that can be caused by many other conditions. Unfortunately, the sources note it's sometimes only discovered after someone has passed away, found on autopsy.
Are there different levels of severity?
Yes, the sources distinguish based on the immediate impact. Massive PE means the patient has sustained dangerously low blood pressure, or is pulseless, or has profound bradycardia. Submassive PE means no low blood pressure, but there are signs that the right ventricle is struggling, RV dysfunction, or evidence of heart muscle injury. And then low-risk PE lacks these severe features.
And pulmonary arterial hypertension, PAH, that's high pressure in the lung arteries.
Exactly. PAH specifically refers to high blood pressure in the pulmonary arteries, the ones carrying blood from the right side of the heart to the lungs. It's defined using specific pressure measurements taken during a right heart catheterization procedure.
What causes it?
It's caused by a variety of diseases that lead to vasoconstriction, tightening, and structural remodeling, thickening, and scarring of those small pulmonary arterioles. This puts tremendous strain on the right ventricle, eventually leading to right heart failure and, unfortunately, carries a poor prognosis. The underlying biology involves inflammation, vessel tightening, structural changes, and sometimes clot formation.
Lastly, in this section, problems with the body's main artery, the thoracic aorta, specifically aneurysms and dissections.
Right. An aneurysm is simply a widening or ballooning of the aorta. The sources give some general size criteria for concern, typically over 4 centimeters in the ascending part, coming out of the heart, or over 3.5 centimeters in the descending part, going down the chest.
Is there a genetic link here, even if someone doesn't have a known syndrome like Marfan?
This is where it gets really interesting. It's becoming increasingly clear that these aortic problems can definitely run in families, even without a classic connective tissue disorder diagnosis.
Really?
Yeah, one study mentioned found that about 21% of patients with thoracic aortic aneurysms had an affected first-degree relative, just based on interview. It seems to follow a pattern that's likely genetic, probably autosomal dominant, but with incomplete penetrance, meaning not everyone with the gene gets the condition.
Does the location matter in families?
Fascinatingly, yes, the location of the aneurysm often seems to track within families. If the initial patient, the proband, has an ascending aorta problem, their affected relatives are more likely to have ascending problems too. If the proband has a descending aortic issue, their relatives are more likely to have descending or abdominal aortic aneurysms. It suggests there might be sort of a division, maybe at the ligamentum arteriosum, between the factors driving ascending arching aneurysms, often non-atherosclerotic, and those driving descending abdominal aneurysms, more often related to atherosclerosis.
So when is surgery actually needed for an aneurysm?
The key insight here is that surgery is generally recommended proactively before a complication like rupture or dissection occurs. Size is the main trigger.
What are the typical size thresholds?
General recommendations are to consider prophylactic repair of an ascending aortic aneurysm when it reaches 5.5 centimeters and a descending thoracic aneurysm at 6.5 centimeters, though the sources note experienced centers might intervene slightly earlier in some cases.
Can you see these on a regular X-ray?
Sometimes. A standard chest X-ray isn't the primary tool, but it can sometimes show clues suggesting an aneurysm or dissection, like widening of the mediastinum, the central space in the chest where the aorta sits, maybe a pleural effusion, fluid around the lung, or displacement of calcium within the aortic wall.
Wow. Okay, we've covered a huge amount of ground from the heart spark and wiring through its plumbing and walls, the valves, the muscle, the vessels it connects to. Now, maybe let's take a step back and look at the tools cardiologists actually use, the diagnostic methods, and the treatments mentioned throughout these sources.
Yeah, it's quite a diverse toolkit. And what's really fundamental, something highlighted right at the start of thinking about diagnosis, is the immense importance of the patient's story, their history.
So despite all the fancy scans and tests, just talking to the patient is still crucial.
Absolutely paramount. The source material really emphasizes that the cause of a cardiac problem can very often be strongly suggested, sometimes even fully determined, just from taking a detailed, careful patient history. Listening is key.
Okay. What about the imaging techniques we touched on?
We've seen how they're used throughout. Echocardiography, or echo that's ultrasound of the heart, is incredibly versatile. It's great for looking at valves, assessing how well the muscle squeezes, ejection fraction, checking for blood clots inside the chambers.
And EAKI.
Right. Transesophageal echo, where the ultrasound probe goes down the esophagus. This gives much clearer pictures of structures at the back of the heart, so it's excellent for looking for clots in the left atrial appendage, checking for small vegetations in endocarditis, or getting a detailed look at the aorta for dissection.
MRI and CT.
Cardiac MRI is fantastic for getting really detailed images of the heart structure and, importantly, characterizing the tissue itself. It can help diagnose specific muscle diseases like myocarditis or infiltrative diseases, and also assess which parts of the heart muscle are still alive or viable after a heart attack. CT is great for looking at bony structures, obviously, but also invaluable for visualizing the pericardium, identifying calcium in constrictive pericarditis, and giving excellent views of the aorta for aneurysms or dissection.
And the more invasive ways to look inside.
That includes cardiac catheterization, where they guide thin tubes, catheters into the heart and blood vessels. This allows them to measure pressures directly, like the gradient across a stenotic valve or the filling pressures in the chambers, and also to inject contrast dye to visualize the coronary arteries. That's coronary angiography.
And RHC.
Right. Heart catheterization is specifically used to measure pressures on the right side of the heart and in the pulmonary arteries. It's essential for diagnosing conditions like pulmonary arterial hypertension, PAH, where those specific hemodynamic measurements are required.
And we definitely can't forget the absolute basics.
Never. The ECG, the electrocardiogram, and the physical exam remain fundamental. Listening to the heart with a stethoscope for murmurs or extra sounds, checking pulses, looking for signs of fluid buildup like swollen ankles or neck vein distension. These are still cornerstones of cardiac evaluation used alongside all the advanced technology.
Okay, let's pivot to some key medications mentioned in these sources. Statins seem like a really big one for cholesterol management.
Oh, absolutely. They are a cornerstone therapy for managing dyslipidemia, high cholesterol.
How do they work, basically?
In simple terms, they work by blocking a key enzyme in the liver, H&G-CoA reductase, which your body needs to produce cholesterol. By reducing cholesterol production within the liver cells, the liver responds by pulling more of the bad LDL cholesterol out of the bloodstream.
Do they do anything else?
Yes, importantly, they also have benefits beyond just lowering LDL cholesterol. They have anti-inflammatory effects within the blood vessel walls, which help stabilize atherosclerotic plaques, making them less likely to rupture. They also modestly increase good HDL cholesterol and lower triglycerides.
Any downsides? Side effects?
Yes, side effects can occur. The most commonly discussed are muscle-related symptoms, ranging from mild aches, myalgia, to more significant inflammation, myositis, and very rarely severe muscle breakdown called rhabdomyolysis. They can also sometimes affect liver enzyme levels.
Okay. ACE inhibitors were also mentioned quite a bit.
Yes, ACEIs are another major class of cardiovascular drugs. They work primarily by inhibiting the conversion of angiotensin I to angiotensin II. Angiotensin II is a potent substance that constricts blood vessels and promotes salt and water retention.
So they lower blood pressure.
They do, but they also have another effect. They prevent the breakdown of a substance called bradykinin, which actually helps to relax blood vessels.
And they're used for more than just blood pressure.
Oh, yes. Beyond just lowering blood pressure, ACE inhibitors are vital medications proven to reduce mortality in patients with heart failure, systolic dysfunction. They also improve cardiovascular outcomes in high-risk patients with hypertension and slow the decline of kidney function, particularly in people with diabetes or other forms of chronic kidney disease.
What about side effects for ACEIs?
The most characteristic side effect is a persistent dry cough, which is thought to be related to that increase in bradykinin. Much less common but more serious is angioedema swelling, typically of the lips, tongue, or throat, also linked to bradykinin, and they can sometimes cause high potassium levels, hyperkalemia.
Okay. There's a lot in here about preventing blood clots, anticoagulants, and antiplatelets. It seems complex.
It is a complex but absolutely critical area in cardiology. Warfarin, the traditional oral anticoagulant or blood thinner, is often used in combination with antiplatelet drugs like aspirin or clopidogrel in certain specific situations.
Like what?
For instance, if someone has atrial fibrillation requiring anticoagulation and also has coronary artery disease needing a stent, PCI, this combination is often called triple therapy.
Is that safe?
Well, that's the issue. A key insight from the sources, referencing studies like WOST, is that while this combination definitely increases the risk of bleeding significantly, maybe 5–10% per year,
Wow.
using warfarin plus 2 antiplatelets didn't necessarily seem better at preventing stent thrombosis, clots in the stent, compared to using warfarin with just one antiplatelet, usually clopidogrel.
So less might be more sometimes.
That's exactly. This is why current approaches often try to minimize the duration or intensity of antiplatelet therapy when warfarin is also needed, balancing clot prevention against bleeding risk. And of course, warfarin remains essential for preventing clots on mechanical heart valves.
And the newer blood thinners, like apixaban.
Right, apixaban is one of the DOACs, direct oral anticoagulants. It's taken twice a day and works differently than warfarin by directly inhibiting factor ZA.
What are the key practical points about it from these sources?
Well, they mention its metabolism partly in the liver via CYP3A4, partly excreted by the kidneys. It's generally not recommended for patients with very severe kidney failure, CRCL15, or those taking certain strong interacting drugs like HIV protease inhibitors. Interestingly, it is approved in the U.S. for patients with stage V kidney disease on hemodialysis. But this approval was based more on pharmacokinetic studies, how the drug behaves in the body, rather than large clinical outcome trials directly comparing it to warfarin in that specific dialysis population.
Can you monitor its effect easily?
Not easily with standard tests like INR used for warfarin. While PT might show some effect, there's no routine clinical monitoring test. However, a specific antidote, andexanet alpha, is available now to reverse its activity rapidly if needed in emergency situations.
Okay, GPIBA inhibitors, those names sound pretty intense.
They are potent antiplatelet drugs, usually given intravenously in acute settings like heart attacks or high-risk PCI. They work by blocking the final common pathway of platelet aggregation, the GPIIBA receptor.
When are they used?
They might be considered, according to the sources, in STEMI patients heading for primary PCI if there's a very large thrombus burden seen on angiography, or perhaps if the initial loading dose of oral antiplatelets like clopidogrel wasn't adequate. They're generally not used routinely anymore alongside newer anticoagulants like bivalirudin during PCI, but might be used as a bailout if things aren't going well.
Any other uses?
Yes. For patients with NSTEMI or unstable angina who are candidates for an early invasive strategy, certain ones like eptifibatide or tyrofibon are often preferred and may be started before the procedure and continued through PCI, especially if symptoms persist despite other optimal medical therapy.
Anything to watch out for?
Definitely need dose adjustments for tyrofibon and eptifibatide if someone has kidney impairment. Abciximab, another one, is typically only used if PCI is definitely planned. And a crucial point, they have no role after someone receives fibrinolytic therapy, clot-busting drugs, because the bleeding risk would be prohibitively high. Going back quickly to artificial valves, preventing clots is absolutely vital. After mechanical valve surgery, the standard practice is to use unfractionated heparin intravenously right after surgery until the warfarin kicks in and reaches its target therapeutic level, measured by the INR.
And that target INR level varies.
It does. It depends on the type of valve and its position. Lower risk bileaflet or current single tilting disc aortic valves might aim for an INR of 2.5, but for mitral valves, older generation aortic valves, or in patients with additional risk factors like AFib, prior stroke, heart failure, or a hypercoagulable state, the target is usually higher, an INR of 3.0. Some guidelines, like the ACCP, actually recommend aiming for 3.0 universally for all mechanical aortic and mitral valves.
Is warfarin enough?
Not always. A really important detail from the AHC guidelines mention is that low-dose aspirin, 75 and 100 milligrams daily, is also recommended in addition to warfarin for all patients with mechanical prosthetic valves.
Why add aspirin?
Because studies have shown that adding aspirin further reduces the risk of stroke, thromboembolism, and even death, despite a small increase in the risk of minor bleeding. So the benefit is thought to outweigh the risk. And, worth repeating again, DOACs are absolutely contraindicated with mechanical valves.
And just to recap, for bioprosthetic mitral valves.
For those tissue valves in the mitral position, aspirin is generally recommended long-term. Warfarin is sometimes used just for the first 3 months after surgery, mainly to reduce clot risk while the valve heals in. And warfarin would also be necessary if the patient has other reasons for anticoagulation, like atrial fibrillation.
Okay. What about medications specifically to control a fast heart rate, like an AFib or atrial flutter?
The mainstays mentioned are drugs like digitalis, digoxin, certain calcium channel blockers, specifically verapamil and diltiazem, and beta blockers.
Which work best?
Generally, the calcium channel blockers and beta blockers are more effective for rapidly slowing down a very fast ventricular rate compared to digitalis. Digitalis works, but it doesn't usually cause acute conversion back to normal rhythm.
And the safety warning.
Yes, that crucial point again. Avoid the AV node blocking drugs. Beta blockers, calcium channel blockers, digitalis, if someone has AFib and known WPW syndrome, due to the risk of accelerating conduction down the bypass tract.
What if the patient also has heart failure?
Good question. In patients with heart failure, digitalis or intravenous amiodarone are generally preferred for rate control over IV beta blockers or calcium channel blockers, as the latter two can potentially worsen heart failure symptoms due to their negative effect on contractility. And just briefly, the sources also mention that other medications have been tested for treating syncope, things like serotonin inhibitors or ACE inhibitors, but note they aren't really used routinely because the trial results have been inconsistent or haven't shown strong benefit.
Right. Beyond pills, there's a whole range of procedures and surgeries we've touched upon.
Absolutely. The toolkit includes revascularization, that decision between PCI and CABG. Valve repair or replacement is a major category, covering everything from traditional open heart surgery to newer, less invasive options like TAVR, transcatheter aortic valve replacement, for aortic stenosis, or even valve-in-valve procedures for failing bioprosthetic valves. We also talked about ablation procedures to fix electrical rhythm problems.
And pacing and ICDs.
Exactly. Pacing and ICD implantation are key procedures to support or rescue the heart's rhythm when it's too slow or dangerously fast.
And surgeries for actual growths in the heart. Cardiac tumors.
Yes, primary cardiac tumors are rare, but the sources point out that even if they are technically benign, surgical removal is often considered urgent.
Why urgent?
Especially if they are large, look friable, likely to break apart easily, or are located on the left side of the heart where pieces could break off and travel to the brain, causing a stroke, or elsewhere, embolize. Myxomas, which are the most common type, and certain types of papillary fibroelastomas, especially large mobile ones on the left side, are examples often needing prompt removal due to this high embolic potential.
Okay, finally, let's look at how the heart interacts with the rest of the body and specific life situations. This is where you really see how interconnected everything truly is.
Yeah, this section really highlights that broader context. Take patients undergoing liver transplantation, for example. They often have a very specific condition called cirrhotic cardiomyopathy.
What's that?
It's a distinct type of heart muscle change directly related to their severe liver disease. They often have this unusual physiology, high cardiac output at rest, but a blunted ability for the heart to respond to stress. They might also have low peripheral vascular resistance, sometimes bradycardia, slow heart rate, left ventricular hypertrophy, and even electrical abnormalities like a prolonged QTC interval.
That sounds like a really challenging situation for major surgery like a transplant.
It absolutely is. These patients are at high risk for perioperative problems like arrhythmias, worsening heart failure, and even heart attacks during and after the transplant procedure. A critical moment is when the new liver is reperfused, blood flow is restored. This causes a sudden increase in preload, the amount of blood returning to the heart, which puts a big strain on that already altered heart muscle.
And other heart issues.
Coronary artery disease is also quite common in patients needing liver transplants, and having significant CAD significantly worsens their outcomes after transplant. So, determining their CAD status before they go for transplant is really crucial.
What about athletes? Their hearts are obviously conditioned differently.
Absolutely. And interpreting an ECG in an athlete can be really tricky. Many findings that might look abnormal in a sedentary person, like certain rhythm patterns, increased voltage, or chamber enlargement, are actually normal physiological adaptations to intense training in an athlete.
So screening is difficult.
It makes routine ECG screening for young athletes somewhat controversial, partly because of the challenge in distinguishing these normal training adaptations from potentially pathological findings that might indicate a risk for sudden death. However, the sources agree that an ECG is definitely a cornerstone of evaluation if an athlete does have symptoms suggesting a heart problem or if they have an abnormal physical exam. It's also recommended for screening in older masters, athletes, say over 40, particularly to look for evidence of prior silent heart attacks.
Pregnancy also puts unique stresses on the cardiovascular system.
Immensely so, and particularly for certain pre-existing conditions. The sources highlight primary pulmonary hypertension, WHO class IPAH, as posing a very significant risk during pregnancy.
How high a risk?
Unfortunately, mortality rates approach 40% in some series. It's so high that, in severe cases, preventing pregnancy altogether or even considering early therapeutic abortion might be discussed because of the profound risk to the mother. Symptoms of PAH often worsen significantly during the second and third trimesters as blood volume increases. These patients require extremely careful management by a specialized multidisciplinary team with very frequent follow-up throughout the pregnancy.
Certain systemic diseases elsewhere in the body can also directly affect the heart. Hyperparathyroidism is mentioned as one example.
All right. Primary hyperparathyroidism, usually caused by a benign tumor adenoma in one of the parathyroid glands leading to high blood calcium levels, can definitely impact the cardiovascular system.
I hope so.
Things like hypertension and thickening of the left ventricle, LV hypertrophy, are sometimes seen in these patients, and the sources suggest these may actually be reversible, may improve after successful parathyroid surgery to correct the high calcium.
What about valve damage?
Valvular sclerosis or calcification might also be seen, but that may not improve after surgery, although it doesn't seem to progress either. Interestingly, the sources note that studies looking at whether parathyroid surgery actually improves long-term cardiovascular mortality have produced conflicting results. Some U.S. studies didn't show a clear benefit, while some European studies did, possibly related to differences in the severity of the disease in the populations studied.
The scleroderma, the connective tissue disease, is another one mentioned.
Yes, cardiac involvement is unfortunately quite common in scleroderma and is a major indicator of a poorer prognosis overall.
Any specific signs?
The presence of an S3 gallop on exam, that's a specific extra heart sound indicating volume overload or heart failure, is associated with a particularly high risk of death. Arrhythmias are also very frequent, especially if there's active inflammation in the heart muscle myocarditis, including PVCs, SVT, and runs of non-sustained VT. Syncope can occur due to AV block or VT. And tragically, there's a high risk of sudden cardiac death, maybe 40–60%, in patients with active myocarditis, usually due to dangerous ventricular arrhythmias.
Let's revisit syncope, or fainting, because the sources give some specific details on diagnosis.
Right. The physical exam is obviously important, looking for signs of structural heart disease, heart failure, checking orthostatic blood pressure, and heart rate changes. The sources specifically mention carotid sinus massage as a diagnostic test.
When is that used?
It's considered for patients, generally over 40, who have unexplained fainting after other common causes have been ruled out. But you have to be careful it's contraindicated if there's evidence of significant blockages in the carotid arteries, a BRUT, or a recent history of stroke or heart attack.
What counts as a positive test?
A positive response, suggesting carotid sinus hypersensitivity might be the cause of their fainting, is defined as reproduction of their syncope during the massage, accompanied by either a pause in the heart rhythm, a systole of 3 seconds or more, or a significant drop in systolic blood pressure of 50 mmHg or more.
And distinguishing fainting from seizures that can be tricky sometimes, right?
It certainly can be. While myoclonic jerks, brief muscle spasms, or twitches can actually happen during syncope simply because the brain isn't getting enough oxygen momentarily, and these can sometimes be mistaken for seizures.
Uh-huh.
The sources list several signs that are much more suggestive of an actual epileptic seizure. These include things like loss of bowel or bladder control during the event, witness tonic-clonic movements, the classic whole body shaking, having a specific warning feeling or aura right beforehand, and perhaps most importantly, a prolonged period of confusion or lethargy afterwards, the postictal state.
Okay. Finally, pacing for vasovagal syncope, the common faint. Is that a standard treatment?
Generally, no. Pacing is explicitly not recommended routinely for typical vasovagal syncope.
But is there any role for it?
Well, studies like the ISU-3 trial did identify a very specific, narrow subgroup of patients who might benefit. These were older patients, generally over 50, who had recurrent episodes of fainting and had a documented prolonged pause in their heart rhythm, a systole typically 3 seconds if symptomatic, 6 seconds if asymptomatic, recorded during a spontaneous fainting spell, usually via an implanted loop recorder.
So only in that specific group.
Yes. In that very select group, dual chamber pacing did show a significant reduction, about 57% relative risk reduction in the recurrence of fainting episodes. However, the key finding was that pacing did not benefit patients who only showed a systole during a provoked tilt table test, but not during a spontaneous faint.
So a very minor role there.
Extremely limited. It's really only considered in specific older patients with recurrent syncope and documented spontaneous asystole captured on monitoring, not for the average person with vasovagal fainting.
Wow. We have truly covered a vast landscape today, starting with those electrical signals, moving right through the physical structure, valves, muscle, vessels, exploring the huge range of diagnostic tools and treatments, and finally seeing how heart health is just so intricately linked to other conditions and contexts throughout the body.
It really does drive home the point, doesn't it? That understanding the heart is often like being a detective. You're piecing together clues from electrical tracings, from images, from the physical exam, and even from how the heart interacts with diseases happening elsewhere.
Exactly. We took these, pretty dense excerpts from a clinical textbook and really tried to pull out those key insights, those maybe surprising facts, those so what moments that hopefully give you a real shortcut to being well-informed without getting totally lost in every single medical detail.
Yeah, trying to find the signal and the noise of all that complex medical information. That's the goal.
So here's a final thought for you, our listener, to maybe ponder based on everything we've just discussed. Considering how conditions like liver disease or hyperparathyroidism or scleroderma can directly impact the heart, how might seemingly unrelated symptoms or conditions you might be experiencing elsewhere in your body actually be connected to, or maybe subtly impacting your cardiovascular health in ways you might not initially suspect?
It's a great question. It's just a reminder that the body is such a complex, integrated system. And sometimes the root of a problem, or at least a contributing factor, in one area can be found by looking somewhere else entirely.
A perfect note to end on. We really hope this deep dive was valuable and maybe sparked some further curiosity for you.
Thanks for joining us.